Great to be here. My name is Shawn Nason. I am CEO and founder of the Nason Group. We are a service design firm that focuses completely on what I call consumer-centered innovation. So, and we work with the whole spectrum of the healthcare. I have a healthcare background. Also spent 7 years working at the Walt Disney Company and was recruited from Walt Disney into healthcare. So, perfect career choice. So we're going to go down. I'm going to have each of the panelists introduce themselves to you and a little bit about what they do, and then we're going to dive into some questions, and then we're going to have some time at the end as well for you to ask questions. So we'll dive in. Sara, we'll let you start, and we can pass mics around. Yep.
Can everyone hear me? Okay. So I'm Sara Kendrick. I'm from SIEMENS Healthineers. So if you don't know, SIEMENS Healthineers is the medical technology division of SIEMENS.
Please speak in the mic, because we're recording.
Oh, okay. Sorry. Is this better? Okay, perfect. Just as a background, SIEMENS Healthineers focuses on kind of several technology areas. We started off with X-ray machines, also work on CT, MRI, and then more recently, as in not 50 or 60 years ago, now into kind of the laboratory space, also with informatics products as well. So I specifically am representing the Innovation Think Tank. So this is an innovation group that is in Erlangen, Germany, so that's where I live. And we are kind of a global organization. Our headquarters are in Erlangen. We have groups in the UK and China, India, Turkey, and in the US. And we're also a kind of a user-centric innovation group, so we're more in the pre-development stage, looking at kind of use cases and requirements development to better inform SIEMENS technologies in the future. So we're kind of technically located as a central function within SIEMENS. We deal with a lot of the different business areas, so we work with X-ray, we work with lab diagnostics, and that's kind of where I am. So thank you, and I'm excited to be here today.
Hi, thank you. My name is Anang Chokshi. I'm a physical therapist by trade and as a clinician, and I'm the chief clinical officer at a company called Reflexion Health. We're based out of San Diego in California, and what we do is we've created a FDA-cleared digital avatar that helps to guide patients through their rehabilitation program post-surgery. And so what we do is that we've kind of partnered with at-risk hospitals who are going in these bundled care ACO models and helping the patients kind of understand what to do at home, how they're doing, and by giving them real-time feedback by using 3D sensor technology. So we're capturing their data as they're performing the activities at home, recording that data, getting health outcomes, trying to make it a little more efficient for the patient where they don't necessarily may have to go into the clinic as often, but providing data back to the clinician to make those clinical decisions. So just trying to make healthcare, as we all, I think all are, more patient-centric, and healthcare a little more convenient for our consumers, and to then also provide data. You know, as a clinician, I wouldn't know sometimes what my patients are doing outside of my clinic, and this kind of gives me an idea of what they're doing and how well they're doing it. And we're trying to work to manage that, improve satisfaction outcomes, and at the end range, overall helping reduce healthcare dollars.
Hi there, my name is Alistair Wickens, and you can probably tell from my accent I'm not from around here, but I'm flown in from London, where I also work in Hong Kong as well. But I've been running in a business for 15 years called Road to Health, which is now the company that sits behind the app called Quealth. Quealth is just a risk prediction model that is now held up as being one of the most accurate anywhere in the world for predicting risks of lifestyle disease. But the specialist area that I lecture on in universities and speak at conferences on is in behaviour change, and particularly working in that area with some of the big universities in the UK and in Hong Kong at the moment. So that's my background. I'm a clinician by trade as well, but as I say, I've been working in digital health for around 15 to 18 years.
Good morning, I'm Doug Sparks. I'm the chairman and founder of DPT Healthcare Partners. After 8 years on Wall Street, in 1987, I moved into healthcare. My partner at the time told me, and mentor said, 20 years from now, in 2007 to 2010, the baby boom is going to hit Medicare age. There'll be the greatest demand for healthcare services, and frankly, physicians don't have a great record of being businessmen. I think you ought to head into that area, so that's what I did. By the end of 1988, I was the chairman of a public company in physical therapy. Once we went through an acquisition there, which was planned from the beginning, I started a physical therapy chain from zero, grew it quite large, sold it out in 2001. Since 2002, I've done nothing but take lessons learned from the private and public sector with regard to partnering with IPAs, ACOs, hospitals, and physician provider groups, and start providing revenue for physicians and those other types of organizations. What we do right now, and our challenges on the technology side, is that we manage the ancillary services for a lot of physician practices. The reason we do that is because 2018 CMS says that 50% of your pay is going to come from provable outcomes, and they don't have any idea what that means. The big problem that we have with the ancillary service part is that everything that we do participating as far as management, like lab, pharmacy, PT, DME, mobile health diagnostic, go down the list, anything the doctor sends out the door, there's only an 18 to 24% participation by the patient once they leave the doctor's office, and therefore there's no outcomes. So even though the doctor's EHR shows what their value-based measures of MACRA and MIPS are, there's no way to tell them why they're failing. The reason they're failing is because you have a patient engagement of 18 to 24%. We put management things in place that'll turn that to 68 to 92% participation in all those different verticals, and we track them. And so what we do is we take those outboard metrics and bring them back in-house for the physician. So we've taken technology to do that. One of the ways we do that is we've tied together hundreds of hospitals, labs, and other producers so we can tap directly into their LIS. We can do patient education, we can do ordering, we can do financial reporting, we can do everything from a single portal. Our biggest challenge we're doing right now is we're working with a group that consists of 2 people who wrote the Obamacare legislation, and we're preparing hospitals and other providers that 2022, they start having penalties if they're not value-based compliant, and again, they don't know what that means. One of the things they have to do is they have to have value-based purchasing, which means it's going to be similar to in-network, out-of-network. By 2022, every service or product you purchase has to be value-based, or it can't be used. So we're early movers on that. One of the guys we work with is a legislation processor, implementer, so he comes in with these things and we get products and services evaluated. We go into hospitals, we have a report card on them in advance where they are as far as deficiencies in value-based, and we turn around and show them where they are. And the big thing we're trying to do right now is we're trying to show them the thing that you're afraid of, which is the value-based compliant, actually is going to give them about a 20 to 30% gain in revenue. You're going to have $1.7 trillion taken out of the market in fee for service over the next 2 years. At the same time, all the disease states that they're trying to fix with value-based is going to create a huge upward spike. So there's a hockey stick growth in value-based. At the same time, the $1.7 trillion is falling out of the fee for service market. And we're trying to show them that there's the time for this, but there's really more money on the value-based side by doing things better for the patient. So that's kind of a little overview.
Awesome, thanks. So we're talking about healthcare and digital and healthcare today and tomorrow. So I had put a few questions together for the panel, and I'm going to allow them to kind of share their thoughts, and wrote them here on my phone, so that's why you'll see me keep looking at my phone. But how is healthcare today keeping up with digital disruption? And particularly think about digital disruption from a consumer perspective. Like our whole life is based around digital. Like you take this away from me, I shut down, crawl up in a fetal position, and don't know what to do because everything seems to be here, right? So our whole world on one side is so digital, but still we're really trying to figure this out in the healthcare space. So again, how is healthcare keeping up with this digital disruption space? And we'll let you guys chime in here.
Hello? Yeah. Okay, there we go. Okay. Yeah, so when I think about that, I think about what I look at a couple of things. I look at, one is what is the FDA doing? I think the flexibility of the FDA to allow for some of this digital disruption to occur is very important. With with the new people who are in there now talking about creating, managing that a little bit is better, right? So they're trying to do it in a way where it doesn't disrupt the innovation of technology, right? And that it doesn't slow down that process as technology gets out there and improves. And I think having the FDA kind of understanding that and being a little more flexible and creating some of these programs, which we all see now, where they're approving organizations that giving them basically, if they have the correct regulatory and compliance type of guidelines and setup, that allows them to approve multiple products. So it's basically, if they have an excellence in their quality, basically they can then, hopefully, then help be able to iterate and innovate faster, right? So I think that's the FDA is definitely helping with that, and I think to help us move in that future, especially when all these devices and apps that are coming out there, that we want to make sure they're medical grade or medical quality as well.
Yeah, so just to ask you a question on that. So even as we were talking about thinking from a generational perspective and the FDA, like, you know, I think when you talk about baby boomers and traditional Gen X, the FDA approval thing is important to them, but then when you look at Gen Y, millennials, and untraditional Gen X, which I happen to fall into one of those untraditional, if you haven't noticed, there's this hair color or something with, right? That's not near as important to us. So there's still people out there ideating. There's these innovation groups, these think tanks that are going, we're not really concerned about the regulatory aspect. How can we still disrupt? How do you think that plays into that? So
when I think about that, I think when it comes to sometimes being adopted more in the clinical world, I still think science takes a little bit of a front seat, right? So I think science is still there. So I think being able to prove that there's a clinical advantage to using the software, there's a clinical accessibility to it. I think all those things kind of play an idea, and that's why when I look at it, I think the FDA is still, for some of these medical products early on, is still going to be the way to go. Even though when it comes to managing a patient, you know, that's their definition. What's managing a patient? What's more of a wellness? And I think when it comes to managing patients, I think the FDA is still going to win out a little bit, even now.
Okay, great. Alistair, Doug, you guys?
Well, I think that I can't speak very much for the US systems, but I know in the UK, the regulatory authorities in the UK are still struggling to keep up with the pace that the technology is advancing at. And as others have said quite eloquently this morning, the NHS is a little bit of a broken system. From an innovator's point of view, from an entrepreneur's point of view, that doesn't stop people like us from developing new technologies and advancing things. And there's a group of us in the UK who are really making some significant advances in that area. The challenge that we have is that in the UK and other territories as well, I can speak for the Chinese territories as well, but there are different systems in different parts of the world, and you've got the payers in the UK tend to be the insurance companies, which is not different, I guess, from over here. But the problem that they've got is that they are mortgaging their existing book of business by getting into bed with entrepreneurs who are developing new disruptive technologies. And whilst there's a will on their part to develop tools and engage with people like ourselves, there is a big barrier, psychological barrier, as to how far can they take that development and support companies like ours. Then you look at the NHS, and the NHS just and I can only tell you from having dealt with it at both a regulatory and a political and a patient and a clinician's perspective, it's like a big business with about 10,000 departments, and you just cannot get consensus around the NHS. So the actual healthcare system in the UK, you cannot get traction with. And that leaves consumers and technologists like ourselves. We're advancing at the speed of light, and the consumers want us to advance at the speed of light, but unfortunately, they haven't yet got the confidence of a single system that will help them and give them real value in terms of looking after their health. Now, where does that leave us all? It means that we've got 4 sectors of society that are advancing at different rates, and that makes it very, very difficult for entrepreneurs like us to make any advance in the UK. In 2005, I actually took my product from the UK, having spoken at the House of Lords and the House of Commons, and tried to get them to engage with us. I took that and took it to Singapore, because it's the only place that I could get to prove the concept. And funnily enough, 4 years later, the UK government went to Singapore to see what a UK company was doing with its healthcare technology. But that's the crazy world we live in.
Yeah, and I would probably say that all of us probably feel that pain here in the States too. We have a system here and we have a system here, and FDA, CMS, you know, big health systems, big payers trying to figure this out, and it's really crippling But it's interesting, as you said, I loved how you said it, the innovators, the entrepreneurs are still pushing on and making advance, even working around the big system. Yeah, Doug?
Yeah, a couple of things. I mean, I'd kind of like to make reference to the real world and not just completely be limited to business. But, you know, my mentor, as I mentioned, that represented companies to Wall Street for 45 years, he used to tell me when there's blood in the streets, there's opportunity. I mean, it's always bleeding in healthcare. That's a lot of great opportunity. But it reminds me of the real world. I'm looking out and I'm seeing all the Apple things here. And I know that in the very beginning, they gave 2,000 Apple computers to school districts to get the kids to begin using Apple. And what's happened today with that? And then again, I mean, I read the 1,100 pages or whatever of the Steve Jobs book, and he talked about, I didn't ask you what you wanted, I showed you what you wanted. And I really believe there's a lot of that in healthcare today. I'm behind the scenes with a big group that you're going to hear more about than you want to hear about, Epic MD, and what they are is they're a giant telemedicine platform. They're taking several avenues to it. We're in the background part. We're going to monetize ancillary services of the physician practices that come in, but their basic thing is an individual can, for $49.95 a month, can have access to telemedicine whenever they want it. Their own doctor can be their doctor. So the doctor will set his telemedicine hours. If not, they'll reach out to an outside person. And so in essence, for $49.95, they have insurance for places where they didn't. They can refer them on to other things. What we do to kind of bridge the gap, I'm saying that we've got to, as much as we do work with the institutional things, as Alistair is mentioning, we try to, as much as we can, not invade, but work directly with the consumers. In that case, like, for instance, we work with a lot of CCM companies, chronic care management and GPO, and the reason we do is because they got a ton of physician clients, but it's a very low margin business. So what we do is we go in and give them the opportunity to work with us on some other platforms that allow them to get, like on the CCM side, instead of just marketing to the Medicare patient base, they're in the doctor's office, contacting, building relationships with those patients. Ours allow them to reach over onto the aisle and be working with commercial patients. And then we give them a revenue model within there that helps afford them to put people in more offices. So between that and Epic MD and other things, the market is going to tell us what they want. And guys like Alistair and the people, and you, certainly all of you, I mean, some brilliant conversation and people in this room. I mean, we're all listening, and we're going to go where they tell us. But there's just, I mean, there tried to be other search engines, but everybody remembers Google. They're tried to, you know, Microsoft, and you can come up with any other operating system you want, but there's only one first to market that moved it that way. There's going to be somebody that does that in these, but they're going to be taking their hints from us. And so, I mean, one of the speakers earlier said, well, you know, the doctor said, the reason she left USC is because they're not seeing things this way. I need to go with people who do see the future. And so I think our involvement with the going directly to the consumer people, but also directly going to the value-based people, I mean, these guys know the rules. I mean, they wrote the law. They know how it's going to be. And so if we can see it from their point of view, and then we can see it from the point of view of the patient consumer, then we can put those together through entrepreneurs. There's opportunities for every one of us in this room to cross-pollinate with each other with those opportunities, with the intelligence in this room.
Yeah, awesome. Do you have any insight for us there, too?
I'll just go ahead and say, so I think I'll probably tackle this question first by talking in general kind of about Siemens and digitalization just briefly, and then also kind of more into how my group works. If you're not aware, Siemens has recently developed a digital ecosystem, which is kind of a cloud-based environment platform that really seeks to aggregate data from all of its different modalities. And so that's kind of its push so far in terms of creating transparency and allowing for kind of insight through big data applications in the future. Specifically in the group that I work in the innovation think tank, I think, again, we're a very unique organization within the company in that, we are very kind of user-centric. Our users in this case tend to be kind of like radiologists or lab technicians, not necessarily always patients. And we also have a lot of different structures. So our group is very interdisciplinary. I have an engineering background. We have those with business backgrounds. We've had medical doctors in our group before. And so we're very interdisciplinary and kind of look at holistic workflows and again, pain points within workflows to really drive kind of what is being developed in the future. Also, a unique thing about the Innovation Think Tank as well is that we have kind of a pulse within university relations as well. So we have innovation research labs, so IRLs, hosted at different universities that we also kind of talk about, and they investigate some of the kind of forward-thinking disruptive ideas that we're talking about. And then the head of the innovation think tank, Sultan Haider, who's my manager, he also hosts kind of innovation management leadership courses as well. So it's kind of the integration of what we're doing, as well as kind of the university focus as well, again, helping to understand and think about these disruptions, more than just on the digital front, but that's definitely part of it as well.
Awesome. We started to dive into this, and I'll get really specific. If you said there was one thing missing today in digital health, as an overall, what would be the one thing you see missing in this space right now in healthcare?
When I look at that, I think there's quite a bit missing still. I think the main thing for me, and when I think of the world that I'm living in, is the reimbursement aspect, right? I think that, or the incentivization to have a reimbursement model to incentivize providers in order to figure out how to use technology to better the care for their patient. So, as we kind of build out these different, doing studies and doing ways to figure out how can we improve the model of our care, I think by not having the reimbursement to reinforce that kind of affects it, or creating these incentivized models. That's what I think.
Great.
I think the key thing for me is that we've got consumers out there who are, at the end of the day, are the end users. If we don't have the engagement of those guys, then we don't have any need to be holding conferences like this. And the missing piece of the jigsaw for me is that we have technology coming out of our ears, and we hold conferences like this and we hear about new innovative things coming forwards. But believe you me, if you go around conferences and you meet people and you see technologies, we have technology to do most of the things that we all aspire to do in this room today. It's wrong of me to say we don't need more technology, but if you get my drift, we have the technology at our availability today to do what we need to do today. The issue for me is that we haven't found a purpose that is compelling enough for the end users to engage. And the minute we do that, I think everything falls into place. Okay, that's it's a view, but I could talk for hours about that, and I've got reasons for it. But it's I think it's consumer that we've got to get their engagement.
Well, and I would add to that, because of what we do as an organization and as a group, is not only just the consumer aspect, but working with a partner of ours this week, and there's still this mindset and mind shift that needs to take place within healthcare that says that the patient, the end consumer, whoever it might be, can be involved behind the secret veil. Like, we need to tear the secret veil down and let them, again, we have a plethora of apps, right? There's so many of everything for every disease state, for everything not getting used, and I am a firm believer in this, is because we are still an industry that builds with a build it and they will come mentality, not a build it because they have asked us for it or they need it mentality. And I get there's a kind of this push-pull, like with the Steve Jobs, you were, but when we come to these great conferences, and I'm not knocking conferences, but what I don't see in these conferences, and I go all over the world and all over the country, is I don't see patients sitting in the room with us saying, this is really what I would want and what I need. And wouldn't it be easier, think of all the money getting invested in technology, if we really understood what the patient wanted and they were with us. I know in the Netherlands, like, they now have a whole patient group, patients included, that actually when you're creating technology, you have to have a patient included, or you can't move forward with it. So I see a mic going up over there. Yeah.
My first thought was that kind of like the Apple crowd, we have to tell people what they want. Because so many people, including just the other day, I learned of my own younger brother running to the emergency room because his gums hurt. And my mom's like, do you realize you just cost the taxpayers $1,200 for something you could have gone to Walgreens for? And there's a lot of people that just, they wouldn't even know how to use this stuff as much as we all think it's awesome.
Well, and we're
have to
highly
teach 'em.
educated, right? We know the system. and it's hard for us to maneuver through the system. So, yeah.
Well, I want to comment to Alistair, because actually England did something way before all the other health systems in the world. It was like in the 1970s, I think they regulated hospice. All right, didn't happen here in the United States until the 80s. Now, why did Medicare do that? Because it was cheaper to die with dignity at home than to have them die in the hospital. And so I hear you guys talking about apps, and I totally agree in prevention. I'm a physical therapist too, by the way. So the alternative opioid is, you know, exercise and nutrition and things. But because chronic health conditions are the biggest health problem, it's like we have to solve their problem. I mean, they want a more efficient and effective access to health care when they need it, and to know when they can go and get it in the local areas. Some of the ideas today were fabulous, because if you created a health home, it's a place you go to first. It's not urgent care. It has mental health, and it's a concept right now. It's being developed in New York. But if it works, it's an extension to the medical model. And my husband's in the film industry, so you had below the line workers and above the line, right? Above the line with the actor, the director, they got all the residuals. But the people below the line on the call sheet were the craftsmen, the food service, all the union workers, right? And so we're really talking about how do you organize below the line care to integrate with the above the line care system, because you're not getting trickle down health care, right? But people want to die with home with dignity. They want to live at home with dignity. So maybe we start thinking about the consumer wants to be at home, healthy and happy. Now, the only way that gets paid, I think, is to go to Medicare and say, we want to try different bundles and incentivize accountable care groups of providers who are willing to work together and not work in a fee-for-service model. Now we have to figure out the payment part, but if every time you're incentivized to make a wellness referral and you both get paid, the wellness provider and the healthcare provider, let me tell you, they'll be referring out to wellness all the time. So they're talking about pay for performance, yeah.
Well, I hear what you're saying about the American system and the concept of what you've got here. But all I can say is that as a healthcare exec that goes around the world and sees different healthcare systems, is that there is a system that is right for each territory and each country. And I can look at the way that the UK system is. We are developing a parallel system to the NHS because that's the only way of operating it in the UK. May not be right, but that's the way it's happening. My work in China is entirely different. But China have taught me something that's very, very valuable, and it's worth sharing it with the conference, is that we look at this because we are physicians and clinicians and technologists who have grown up in the Western world knowing what the healthcare system is in which we live. And therefore, that is shaping every single one of every single one of us think in this room. But you start working outside of that box, you start to see that by tipping the system upside down and doing it in a different way, opens your mind up to completely different ways of funding. Now, I would take issue with your issue about you have to go to this person to get paid, because I've seen systems that don't require that. But yeah, and I'm not talking about China, I'm talking about different systems that even operate in the UK. But China are using technology in a very, very interesting way. Most of us will say, let's get a healthcare, we've got a healthcare platform, a system, the UK system or the US system, where you've got the hospitals and everything like that. When you go and see a doctor, he then prescribes something for you. Now, in that case, it might be, in this case, a telehealth option. But what they're doing in China is turning that upside down by putting telehealth before the healthcare system. And that actually is if you think about the economics of that, that's a very, very, very good way of dealing with a problem where they haven't got enough doctors to go around the head of population. There's 1.2 billion people in that country. 35% of them are pre-diabetic already, which is a shocking statistic. And that is where the innovation is coming in at regulatory and governmental level, not from individuals like you and me.
Yeah. I know the Netherlands has done something similar to that too. So let me ask you guys, and then we'll get some more questions here. If there's one big disruption you see coming in the future in this space, what do you think it'll be? And we'll let each of you guys kind of answer about that. Well,
Again, back to the value-based thing. You know, one of the things that they're doing, which is very unique, and I totally agree with Alistair that the telehealth is going to be the head. It's going to be like the new gatekeeper to get them out to where they need affordably. I think that's going to happen. But on the value-based thing, one of the things they're doing is, in the process of getting a service or product validated, they're going after the high disease states, the ones that have been mentioned several times here. And so what they're doing in that case is to validate a product that has 10 goals, that are 10 standards it has to reach. And this, again, was written by the two physicians who wrote the Obamacare value-based piece. And they're partners of ours in a separate company. And so once it reaches that status, then it gets what's called an exemption. And once it has an exemption, then it rolls out in their market. Right now, they have the contract for the VA hospital. First thing they do is they go in and every service the VA hospital product, if it's not validated, they're replaced with a validated product. And the reason they do is because value-based medicine is going to share the savings. So to give you an example, there's a new knee product out or service it actually is a larger gauge needle, and it can go into the knee, take the picture, make an injection, do the meniscus repair, and come out for $1,300 instead of $30,000 if you did the MRI and everything else to their staff. So what they're doing is that, you know, do the math on that 50% of that savings goes to the providers. And so the incentive is that, but the hospitals look at it a different way. They're only engaging 20% of their local market. So what they do is, with these validated products, first of all, with validation comes 100% adjudication from all payers. And so the next thing that happens is they put that into the network, and now it's being steered by the payers to these high disease state solutions, which have been validated. So what's going to happen is, with the blessing of the hospital and the payer, all of the community is being called and said, you're eligible and available for these free services, and we need to know where you are because we need to get you healthy, get you in advance. And so they're reaching out to the consumer. So there's just a number of things, but if I had to tell you the one thing that's going to change, that's going to make a huge difference is, just like law enforcement, you hear the complaint all the time about hands not shaking hands. They don't know it's in that system's right there. Why don't I have access to it? And that's one reason we spent the time and money we did with these IT partners to deliver. We literally have connected over 2,000 providers, including hospitals, labs, pharmacies, all through one portal so that everybody can see encounter data. I mean, we're allowed where it's appropriate. Everybody can see billing and collection data. Physician can make an order, patient can see the results on one portal, because we need to have interconnectivity in the whole system if we're to get any metrics to go. So if you take it back home, like Alistair's saying, into the telemedicine part, and going out and learning from the consumer and taking what the consumer's doing, and that's exactly what Epic MD says. Their telemedicine is going to give actual access to healthcare, affordable access, and that person's the gatekeeper to other services. Now what we do is we come in the back door and we create that network that they're sent to, and then we monetize that for Epic MD. And I'm really interested in talking to Tim. He's left the room, but I'm interested in talking to them about how about we can monetize some of that back to the patient and the way these rewards go into these health savings accounts for how it would go with her. So there's a number of things we can tie together, and there's brilliant minds in this room, and I appreciate all the input from everybody.
And going back to the telehealth thing, so what's interesting though, total firm believer in it, but I was sitting in a room Tuesday night for a very big healthcare organization here in the States, talking with patients, members, consumers, getting feedback, and we mentioned the word telehealth, and 90% of the people in the room still did not know what telehealth is.
Microphone, please.
Yeah.
That's a great point. The reason that I got involved, and again, I'm not a frontline person, we're behind the scenes thing, but the whole reason I got involved in the project for Epic is because you're going to use your own physician. I'm not interested in telehealth. I mean, I'm in Austin. Well, we split time between Dana Point, California, and Austin. And so when I'm in Austin, my physician's in Houston. I don't want to get in a car 2.5 hours to go see him. I'd love to have a telehealth. So the doctor makes $50 for the conference. It's typically 6 to 8 minutes. It's a patient he already knows. He can do what he needs. It sells him. He can fill his schedule that way. It's a convenience factor. But if they weren't offering my physician, I wouldn't be interested. Now, my physician may not be available, and then I'm okay with somebody else. But at least I'm getting my physician. So I think that's going to be a big difference in acceptance for the population.
So my still push back here. Like that was offered to these people. You still get your provider. We have this education gap still happening. Like Patients don't trust it, still don't even know what it is. And frankly, we as an industry can't even call it the same thing. Some people call it telemedicine, some people call it, I heard it called Well Connect the other night. All these things, like, we need to figure out how to make that, again, back to let the patient know what they may not know, but we still got to get them educated. So other disruptions real fast, and we'll open it up for some questions.
Sure, yeah, I might answer your question by not answering your question a little bit. So again, we're a central innovation group that kind of looks at a lot of different modalities, and so we kind of tend to look at a lot of different types of disruptions. We also host hackathons. We have other sorts of events where we're kind of always looking at where kind of the technology meets what we currently offer and how that can impact an end user. So, I mean, if you were to like pull my arm at this given moment, I'd probably say something, again, along the lines of what Dr. Sullivan said with blockchain possibly as a disruption and something to be investigated in the future. But and kind of not answering your question, I think that's kind of our focus. So we tend to look at a lot of these different kinds of disruptions, both in the digital space and outside of it, and how they can really impact an end user in the end. So that's my answer.
Disruption?
Yeah, I think the next disruption is going to be, I think EHR system's been out there and Epic and everything like that. And I think what it's done now, as we've done that, is we've kind of dehumanized the interaction with the clinician, right? And so, because everyone's, their heads are into the computer, they're typing away. And I think what has to come back in here is some way to extract that information from an EHR system and provide it to the clinicians, and maybe even do some voice and AI and deep learning, all these buzzwords we all hear about, right? Just a way to where the humanization, the human part of the interaction with that patient, be it a telemedicine visit, because we're all big on telemedicine and tele-rehab, and building that interaction and bringing that relationship back with that clinician.
So, thank you. I'd get on the table and dance here if it would be appropriate. Yeah, absolutely. Love that thought. And I actually get tired of hearing people talk about what if we could Uberize healthcare. Remember, Uber, all of those things are transaction A to B. Here, I need to go from this point to this point. Thank you. Just took an Uber here from someplace else. There's still the part of healthcare that is so missing now. There's still a human. We're all still humans. We all still want connection. We all want it in our lives every day. So how does technology become the enabler to provide that human connection? I think is a great insight, is what I was hearing from there. Like, I call it just humanized health again, right? So Alistair, anything from you, big disruption, and then we'll open up for questions.
Well, I can't predict, and I don't think any of us can predict what the next disruption is going to be. The one thing I would say that is very consistent is the speed at which the technology is advancing means that we have to take action and do something about it today. I've been an innovator in entrepreneurship for 15 years, and I've morphed my business from top to bottom 4 times in that period because the innovation in the world and the technology world has demanded it. And my big challenge, and I'm going to be a bit provocative on it, and I do that when I go to conferences, it sparks a nice ambience in the room, kind of. But we do not know what technology is going to look like in 12 months' time. Not one of you knows what technology is going to be like in 12 months' time. And we're here trying to procrastinate and talk and deliberate about what we should do to try and solve the problems of the next 5 years. My friends, we do not know what the technology is going to be like, and we can talk about telehealth, but telehealth may not be around in 12 months' time. It may be replaced by some technology that we know nothing about at the moment. The speed of which technology is advancing is incredibly fast. And my plea to everybody that's in this room is let's stop talking about what we should be doing and try and get some traction with what we've got. Because if we could do that, we could then possibly get some volume, and we could possibly then get the end users to actually understand how to use the technology. I am not surprised we have problems getting consumers to engage when we throw a bit of technology at them every single week. And that's a fact. Why can't we get something like Facebook? I'm not saying Facebook should be the vehicle, I'm saying, why isn't it that we cannot get the same magic ingredient that Facebook have got, that every single one of us in this room knows how to use Facebook? Why can't we do that with health technology? It's because we are throwing too many ideas. We're procrastinating. We're just a load of old winch bags. We sit in rooms like this talking and deliberating about what technology should be doing. But we're not getting traction because there's too many options.
Awesome. Questions?
Any questions?